thought we could take a couple minutes to talk about this learning community and what it is and orient everyone on the call to why we're doing this.
Great. And maybe we can talk Ian into not retiring so he can keep staying on the call.
If you guys could help me with that, yeah, please. Welcome, Ian.
Hey there.
But why don't I jump into content and then we can talk about the learning community as a break before Greg talks about his the journal articles. Okay. So let me pull that up. And as people are joining on, welcome. Thank you for joining our learning community. Let's see. What am I doing here? Okay. Sharing. Hmm. Is this the one that I wanted to share? This is not the one I wanted to share. Here we go. Oh, I keep hitting the wrong button. Okay, this should be it. All right, thank you so much for joining. Looks like we still getting some people jump on. So I'll go ahead and start with the presentation I was planning to do today, and then we can talk a little bit about what this learning community is about and hopefully get you guys to want to come back. And then we'll go into Dr. Gahm's update on journal articles. So today's topic that I'm presenting is called Who Pays in Post-Acute and Long-Term Care? And of course, I am not the world's expert on this topic, but I think it's a very important one. And I put together some information that I think represents what I think that clinicians who are working out in the field should have a working knowledge of in terms of payments and how our patients are getting their care paid for and how we're getting our services paid for as well. As I'm going through these slides, if you hear anything that I say wrong, please correct me. I don't pretend to be an expert. If you have some comments, please feel free to chime in. And basically, these slides that I got today are based on the American Geriatric Society Geriatric Review Syllabus. They have a set of teaching slides, and this comes from the teaching slides on finances. So I broke down this talk today about the role of Medicare and Medicaid, and also to discuss some payment models that are specific to our post-acute and long-term care settings. So let's start off by each of us kind of disclosing which setting do you can't even talk, primarily spend your time serving? You can put it in the chat box, or you can just come off mute and let me know. Are you mostly skilled nursing facility, long-term care, assisted living? I don't know if we have people on here who are focusing on group homes and home visits, or if you're in a clinic. You're welcome to put that in the chat box or just tell us. I figured we would have a variety, somewhat of a variety. We're probably mostly focusing on the facilities. Okay, yeah, thank you. Yeah, thanks for popping that into the chat box. I'm just still trying to navigate my screens here. Well, healthcare is pretty expensive no matter which setting you're in. And this graph shows the amount of spending from Medicare year over year. And you can see it keeps going up. And these are dollars in the billions with a B. So of course, there's a big need to understand how things are getting paid for and to find a way to control the costs so that we have enough to continue with the great care that we all want to provide. And let me just ask you to think about this question, true or false? Long-term care insurance pays for the majority of nursing home stays in the United States.
False.
Hopefully you agree with Greg, and that's false. Yeah, that's what I was thinking too. It turns out that long-term care insurance actually only pays for less than 2% of nursing home stays in our country every year. Medicaid is our primary payer here. And if you were thinking Medicare, just remember Medicare pays for skilled rehab after someone has been in the hospital for 3 midnights, and it does not cover long-term care. When someone is in the nursing home for long-term care or custodial care, most of our residents are using Medicaid. The other ways to pay for it would be private pay. Or if you're one of those people in the less than 2% who are using long-term care insurance. What's the difference between Medicare and Medicaid? Well, Medicaid is the joint federal and state program, meaning that every state has slightly different variation of what Medicaid looks like. This is the healthcare insurance for people of all ages who have low income and limited savings. The income eligibility is based on a formula, and they're using this modified adjusted gross income. I had to look it up, but right here in Colorado, for people to have Medicaid if they need that to pay for their long-term care stay. In Colorado, the asset limit is $2,000. The monthly income limit is almost $3,000. And there are different ways that these are calculated, different exceptions, and different rules that people have to follow in order to qualify for Medicaid. Medicare is the federal insurance program run by CMS. This is for Americans who are at least 75 years old. They can be disabled or have end-stage renal disease or ALS. There are no premiums for older adults and spouses who have had Medicare taxes deducted from their paychecks for at least 10 years. And this is the insurance that pays for hospital stays and subacute rehab care. Medicare is broken up into parts A, B, C, and D. This slide reviews what is covered under each one of those parts. And you might already be familiar with some of this. And the way I thought we could talk about it is just think about one of our patients. What if Mrs. Jones is hospitalized for like pneumonia? Who is paying for her hospital stay with the tests that she needs and the medications that she gets in the hospital? Is it part A, B, C, or D? And hopefully you're thinking part A. When Mrs. Jones
A,
is A, yeah, okay, I agree with you. Thank you. When Mrs. Jones is discharged from the hospital and she has to go to a skilled nursing facility, who's paying for her SNF stay with the medications and the therapy that's involved with that episode?
A,
That's part A. Agreed. So how about when a nurse practitioner or a PA or a physician sees Mrs. Jones in the hospital? Which part of Medicare is paying for those visits?
B,
That's part B. Agreed. What about the practitioners who are seeing her in long-term care or assisted living? Who's paying for those visits?
B,
Part B. If Mrs. Jones gets discharged and she's seen in the clinic, and the physician or an NP or PA are seeing her, which Medicare part is paying for those visits? Easy, part B, right? So just to keep in mind, I think it is very interesting that our nursing home patients, their hospital stay, their nursing home stay is paid for by a different part of Medicare than the practitioners that are taking care of her. And that might answer some questions if you have some questions on, gosh, why are things so different in terms of the priorities? It might be because of the way that the reimbursement is coming from different parts of Medicare. If,
Singh, I have a
yeah,
question.
yeah.
Leanne Berg here. It used to be the patients had to pay for their Part B coverage, had to pay a premium for that, so that not everyone who had, quote, Medicare, unquote, had Part B unless they had paid the premiums for it. Is that still the case?
Believe it is. If anyone knows differently, please speak up. They are
yes.
separate premiums.
Yes, you still have to opt into it.
And not all patients have done that.
Correct.
Yeah. And you have to sign up on time to get the best premiums too. There are different rules regarding that. Yeah.
Yeah,
So that's
and
good to know too.
yeah, and even along with that, you have to sign up for Part D, even if you're not on meds initially, or if you delay that for years until you do go on meds and want it, there's a penalty built in that you pay extra every month.
Mm.
Yeah, I had a patient years ago who continued to drive a truck for about 20 years after he was Med A eligible. So he never signed up for Part B. And once he did in his 80s, he got a whopping huge bill that he couldn't pay, like $70,000 or $80,000 for past premiums for Part B. So it can be a rude surprise for people who work and have commercial insurance after age 65 who don't think they need Part B. So we'll occasionally see those people in the nursing homes who don't have Part B.
And it's not too late for them to get it, but they might owe some fees
Oh, a huge
for
fee
being
if,
late.
if it's been
Wow.
10, 15, 20 years without having paid the premium.
Gotcha. Okay. Wow. Yeah, thank you for highlighting that. And thank you, Linda, for your comment. It's a very confusing system. I agree. Some people even enroll in Medicare Advantage plans, and these are going to be managed care plans from a private insurer that covers parts A and B. And so, um, if you've heard Medicare Advantage, we often call that Medicare Part C. And then what Lee and Greg just mentioned about drug coverage, there are prescription medication plans that would be considered Medicare Part D. You might have also heard of Medicare supplemental insurance or gap insurance. True or false, Medicare supplemental insurances pay for these items: routine dental or foot care, hearing aids, routine eyeglasses, orthopedic shoes.
Unknown.
Unknown.
None of the above.
It depends on the policy.
Depends on policy. So they're saying it's actually like none of the Medigap will pay for these. The supplemental insurances that are for Medicare Medigap can only cover holes that Medicare provides. So it can cover co-insurances and deductibles for things that Medicare covers. And because Medicare does not cover routine dental care, hearing aids, routine eyeglasses, and orthopedic shoes, the Medicare supplemental insurances actually can't pay for them either. Is that what you know to be true? It doesn't
Yes.
sound like that's the way you responded.
Yes.
Okay. And so really to get these kinds of things covered, like dental care, routine hearing aids, routine eyeglasses, most people either have to pay out of pocket or they have to be on Medicaid and hope that Medicaid pays for it. Or some Medicare Advantage plans are permitted to cover these too. Well, Medicare has various payment models that affect our practitioners, the NPs, PAs, and physicians. And there are different models that pay our long-term care stays and our SNF stays. And I wanted to just open these up and touch on some of them so that you're familiar with what they are. And if you have questions that I can't answer, I will definitely try to help find the answers. And we've got a lot of smart people on this call too, of course. But as we mentioned, Medicare Part B is what pays the clinicians, whether the patient's seen in the hospital or in the nursing home or at home or in clinic. A fee for service is the system where Medicare pays based on the service that's given. And physicians and NPs and PAs have the options to participate in Medicare. You can be a non-participation or be an opt-out private contracting. People who are participating in Medicare are also eligible to participate in value-based contracting through Medicare. And the reason I just point that out, first of all, is to highlight that there's these differences between fee-for-service and value-based contracting, but also that it is a choice to accept payments from Medicare. And there are people Probably not the ones that we're working with in our nursing homes, but there are people who choose not to accept Medicare and they are not subject to the same rules. The fee for service essentially means that for each service, for each visit, there's a reimbursement for that service. If you are in that kind of system, you're probably intimately familiar with the codes that go with each visit. Everything from 99304 to 306 for your new visits, and your 99307s to 99310s for the follow-up visits in the nursing homes. This is just an example of some of the requirements for billing for that and the reimbursement. Of course, there's a separate list for assisted living as well as house calls and clinics. But fee for service means that for each service, you get a fee for it. Value-based care shifts some of that to giving incentives or providing payments based on the results of the care and the value of that care rather than the volume of how many visits. Perhaps you've heard of MIPS, the Merit-Based Incentive Payment System. This is a system that's undergoing a lot of reform. It is based on not just strictly reimbursement codes, but it provides incentives and adjusts payments based on quality metrics. There are also alternative payment models, which are even more structured towards that value-based type of care. If you've heard of ACOs, that stands for Accountable Care Organization, and bundled payments, BPCI programs, these pay groups of practitioners for the outcomes of the care received for certain patients rather than the specific visits themselves. Dr. Walter Lin said in 2025 that the future is bright for post-acute and long-term care under value-based care. He came and spoke at our annual conference here in Colorado, and the next two slides were some of my takeaways from what he said and why I think he said this about the future being bright for our settings under value-based care. So I'll show you these two slides. The first one is a graphic that demonstrates that value-based care can be seen as a spectrum. On this graphic, on the very far left, are the fee-for-service types of practices, where every visit gets one reimbursement, and that's called fee-for-service. It is a volume-based type of system, where the more visits you do, the more payments you get. The more complex each of those visits are, the more payments you get. Compare that to the very right side of this graph, where they're calling population-based payments. The payments are based on who that practice is taking care of and for what period of time. And it's completely based on the value-based and not at all based on volume of visits on a day-to-day basis. And the way this graphic is structured shows that it's a spectrum. There are different models in between those two extremes. Maybe you've heard of MIPS, or you've heard of ACOs or iSNPs. They all fall somewhere along this spectrum. This next slide shows on the left side the current state of practices and where we fall on the spectrum compared to our future state. So on the left side, you can see that right now, big orange circle represents that most of our practices are providing fee for service. There's no specific link to quality and values with incentives. In the future, the way that Medicare is pushing us all towards is for that big orange ball to shrink so that almost no practices are just doing fee for service, but that everyone is in one of these other models, that there are payments for quality metrics, that there are going to be payments for taking care of specific populations of people, rather than focusing on the volume of visits and the complexity of each note that's written. Hope that makes sense. We can move on to the Medicare plans for long-term care residents. As we mentioned, Medicare doesn't pay for long-term care stays, but there are programs like the PACE program, which is a combined Medicare and Medicaid managed care model. It provides comprehensive health care for people who require nursing home level services. And these services includes the patient's primary care, their prescription drugs, home care, transportation, and it pays for their nursing home stays. Special needs plans are Medicare contracted plans through Medicare Part A and B that are generally run by Medicare Advantage. And there are different types of Medicare special needs plans. The ones that you might be familiar with here in Denver would be the institutional special needs. These are SNP plans, SNP plans for people that live in an institution, like a nursing home. There are also institution eligible plans, i.e. SNPs, for people who live in assisted living. And here in the Denver metro area and in Colorado, you've probably heard of Optum. That's who I work for. There are other I-SNPs like longevity, the perennial advantage plans, and these will cover the patients who live in nursing homes. That's why you're seeing them in your facilities. There are also D-SNP programs called the Dual Medicare Medicaid Special Needs Plans. These are for people who have both Medicare and Medicaid. And there's also Chronic Condition Special Needs Plans, or C-SNPs, for people who might fit under a certain category based on a chronic disease. So these are just different ways that Medicare is trying to address some of these special needs and provide for people who might require long-term care. This is just a graph to show you that Medicare Advantage is here. It's kind of here to stay and it's growing. A number of people who are in Medicare who are specifically using Medicare Advantage has been growing each year. And finally, how do our SNFs use Medicare for our SNF stays? They're not just fee-for-service anymore either. They have value-based purchasing programs for our SNFs that incentivize the facilities to avoid high-cost things like hospital readmissions and incentivizes the facilities to meet certain quality metrics and get payments based on that. In the last few years, since 2019, you've probably heard about the change in the way SNFs are being paid. And the change essentially went from this previous model based on certain categories of complexity for each SNF patient over to this PDPM model, which bases on multiple clinical needs of each patient. And the SNFs get paid based on the level of need and this, according to this calculation. I know when I was working in the SNF day to day, this became a big deal when PDPM came out, emphasizing that as a practitioner, I need to be very careful about what I'm writing and documenting and be sure to capture every single condition and need because that was going to affect the way that the SNF was being reimbursed. So that is all I have for the formal slides. I welcome any questions. And included in this slide deck are the next few slides. Well, there's the references, but also just from the American Geriatric Society, a short glossary of some of the healthcare financing terms that you could use for reference. Any questions or comments?
Seeing Lee Annenberg here.
Hi, Lee.
Thank you for that nice summary.
Upstairs, I'm on a call.
I find that there's regional variations in a lot of these things in rural areas where there's not a high density of patients and a very low density of providers. It's very hard for these Medicare Advantage plans to have sufficient volume to bring together providers and organizations for payment. And so there's the Front Range of Colorado from the mountains out 20, 30 miles is probably a high density of these plans, but out way east along the border with Kansas and Nebraska and maybe down to the corner with Oklahoma, there's almost none of this. So it's hard to fathom how going forward 5 or 10 years, the government will transition over to what I call prepaid care, where they give Medicare Advantage a block of money for a given volume of patients, and then they're responsible for the care for that year. And from a governmental perspective, that makes a lot of sense to make the Medicare population costs predictable. As it is now under fee-for-service, they have up to 6 months after the calendar year to get the bills in, and they won't even know what the year 2025 costs until the end of June. So because there's 6 months to put in the billing. So I think the push will be for Medicare Advantage, but I think the challenge will be the rural areas that find it hard to implement this. So your thoughts are there, does Optum go out into a community of 40 people and try to enroll, the 10 elders in that community and then no providers to take care of them?
Yeah, I
I'll
think that
throw in,
you're right. Oh, go ahead.
I was going to throw in one comment. Part of the problem is the requirements for those Medicare Advantage plans, because they have to provide equal access to specialists or ready access to specialists. And you just can't, and they define that, and it's, I don't know what it is, saying you may know 20, 30 minutes or 30 miles, or it's some weird thing like that, but you can't do that. I mean,
Right.
you don't have enough.
200 miles becomes the closest for some of these communities to
Yeah,
get to a
yeah.
sophisticated healthcare center.
So you just can't meet until they change those requirements. I don't think it's going to happen.
I think that our rural patients deserve like the best care just like anyone else. And if we need to be more creative in how we're designing those rules and making exceptions for communities that have a hardship, that can be done.
Yeah, telemedicine has been a big improvement to provide assistance from a distance. But if someone's complex and needs a careful physical exam, it's difficult to do that over a tablet.
Mm-hmm. Mm-hmm. Yep. And what is the role of telemedicine in meeting these requirements and stretching good care further? Um, I think we're still working that out, both on a practical level and from regulation standpoint. Any other questions? Yeah, thank you for your perspectives on that. Certainly the system's not perfect, and as providers who are trying to just do the best job we can for our patients at the bedside, sometimes these types of structures and payments do get in the way. So I appreciate you listening and taking part in the discussion, and I hope that you'll keep continuing to learn so you can bring the best to your patients. And then if we have questions as a community, we can get them answered. Let me pull up my next brief set of slides here. I wanted to go over what this learning community is about and ask those of you who are here today some questions. And when I'm done, we can go into Greg's updates about journal articles. The PALTmed-Colorado is continuing our first Thursday education on Zoom. We're calling it the Learning Community. And this is going to take place of our previous journal club. Let's see. What we like to do is invite all of you to continue joining here the first Thursday of each month. We're extending it to 1 hour instead of half an hour. We're also having an in-person session on Thursday, October 22nd. That should be around 9 a.m. to 3 p.m. in Denver at the Lowry Event Center. I believe, Ian, we already have a hold on that day, right? And we're kind of confirmed for that date and time. These virtual
Yes.
meetings, yes, okay, thank you for confirming that. Yeah. These virtual meetings are free. We have applied for CME. That hasn't come through yet, but our goal would be to provide CME to be free for our members of PALTmed-Colorado. So now might be a good time to make sure that you have membership and that is up to date. And for the in-person part, we have some registration details coming. The purpose of this is for us to all get together to learn from each other. We want to connect with you as colleagues. And ultimately, of course, we want to improve the care for our patients. Our target audience are the clinicians in the post-acute and long-term care settings, all the settings that you guys all just mentioned recently. And my thought is that this is going to be more the clinical side of things, a little bit less the medical director side of things. There certainly is a lot of overlap. Oops. We have, I guess I might let's go ahead to the next slide. We've already lined up our topics and speakers for the year, and that's because we do want to try to apply for accreditation to provide CME for people who join on. And as you can see, these are topics that we think are important for the bedside. These are presenters from right here in your own community. These are the board members of PALTmed Colorado and our education committee who are going to bring the best of what we know based on the evidence, based on the research, based on the journal articles, and also making it real for the bedside. And while none of us is the world expert on any of these topics, I think that we have a lot to offer. And with our community together, we can all ask the right questions and come up with what is the best evidence base for each one of these topics. So we do want to call this a learning community. This involves you being part of it, and it involves us as board members bringing some topic that we think is important for the bedside. So a couple of questions I had for you all. First of all, for this in-person session in October, which is Thursday, October 22nd in Denver, how much would you pay to attend something like that? Let's say we could give you 4 hours of CME.
Before we answer that, Singer,
Yeah.
can we remind everybody that starting in 2027, CME will be required for your license?
Very important. Yep. Yeah. If you don't want to commit to an answer to my question, that's okay. You can send an email or, yeah, thank you, Dr. Birmingham. Yeah. So our board is trying to put this together so that we can make something that's fair and accessible and try to encourage as many people to take advantage of this education as possible. The other question I had was a little more theoretical, but can you each think of 2 or 3 people who aren't on the call today who should be on the call? And can we get them to join next time? And this will be for our virtual calls every month, for our in-person session in October. And because if we're going to learn and connect and improve care together, we need all of our clinicians to do it. So
So
that's my,
saying this is Roger, and
hey,
easier
Roger.
for me to say this rather than to type it in.
Yep.
I think if you could send this information out about the schedule, not just to members, but to the large provider groups, whether it's Summit or Rocky Mountain Senior Care or other large groups, and push people like Raj or Vikas in case of Summit to get their providers to sign on, even if they're not part of PALTmed-Colorado. I think that would be great.
I agree. I think that's an excellent strategy. Just hitting our big provider groups will get a lot of people this information. Mhm. And we'll put this on the website, of course, blast it out on our email distribution list, but also individually invite the groups. I will stop sharing. Are there any other thoughts about the learning community? Well, if not, thank you so much for listening. Thank you for your time. And we'll continue to take your input. We want to do this the right way and be very effective and hopefully really impact the lives of our post-acute long-term care patients here in Colorado. So our next speaker is Dr. Greg Gahm.
Yeah, and I just sent a request to be able to share. Let's see if we can get it. Oh, good.
And for those of you who just logged on at 12:30, just wanted to remind you that our learning community is going to continue every first Thursday of the month, but we will be from 12 to 1 from now on. So I hope you'll have time to stay the whole hour next time. Thank you.
Okay, so my initial intent for today was I'm going to go through this pretty quickly, um, was to talk about a number of articles I've been collecting over the months and try to hit several things. And I got bogged down in the first one, and I just thought that presenting a bigger picture of this would be better than 10 different things. So we're going to spend a few minutes talking about fish oil, omega-3, in part because so many people are taking it. And, and I always ask why, but, so why fish oil? And these are the reasons I came up with. You guys may have other reasons. It is known that there are populations that eat a lot of fish, particularly Japanese Scandinavians historically. that live a long time. Everybody wants what they've got. Taking omega-3 is pretty harmless. It's affordable. Um, and oftentimes, as I talk to people, they think it'll offset the bad habits they have in their life that they really haven't committed to changing. And I listed some of them here. Don't want to get vaccinated, don't want to give up smoking. I love eating food, and well, I'm getting older and I'm not exercising. And they think this pill is just the fountain of youth. Ponce de Leon, 2026. And it's intriguing, misleading advertising that you get on TV and everywhere else, because it's not a controlled substance of any kind. And so then the question becomes, does it work? So what I put together is 2 decades of evidence about fish oil. So I'm going to go through these really fast, and I'll send the references out to anybody that wants them. I keep these digitally so that I can share them with people that don't trust that what I'm saying is true. And then I just say, read the original article and then let me know. So first one is just the effect of fatty acids on risk of atrial fibrillation. It's a randomized controlled trial from 2021. And at the end of this study, 81,000 patients. It was a meta-analysis, 7 randomized controlled trials. The average age 65, 5 years of follow-up. And if you looked at those studies, the people that were taking the omega-3s had an increased risk of atrial fib, not decrease. And the risk was higher in patients that were taking more than a gram a day. Okay, so there's a failure. Second one, people of risk of cardiovascular disease and mortality, people with or without vascular disease. This was a, big, again, amalgamation of data from 58 countries. This is from JAMA about 5 years ago, 92,000 patients. Morbidity and mortality of major cardiovascular events, heart attack, strokes, heart failure, mortality. And what they found in their pooled analysis just was that it didn't work in the general population. If you already had vascular disease, there was a slightly decreased risk of worsening disease and bad outcomes. But if you're just taking it to try to prevent that stuff, didn't work. Okay, moving on. Here's one cardiology, JAMA cardiology, and just general health claims. And so some background information, about 20% of the US population over age 60 take fish oil supplements. And they just take it for heart health, despite what we're about to talk about the rest of the day. Results showed that the majority of fish oil supplement labels make some sort of health claim, usually some sort of structure, functional claim that implies a benefit. A lot of heterogeneity, but no data behind it. From JAMA, again, 5 years ago, omega-3s versus placebo for depression or clinically relevant depressional symptoms, mood. There was a small but statistically significant increase in the risk of depression or clinically relevant depression symptoms in the people taking it. No change in mood scores over 5 years. So again, it not only didn't do what they said it should do, it actually was the opposite. Here's fatty acids versus corn oil was the placebo. Major cardiovascular events from JAMA 2020. And again, I'm just going to hit the highlights. There was no difference between the two. Same, let's see, this was 13,000 people, double-blinded, randomized control trial. No clinical benefit, no harm versus placebo, but no benefit. Here next is from JAMA This one's 14 years ago, but again, looking at major cardiovascular diseases. It was a meta-analysis, 69,000 patients, followed long enough that there were just over 7,000 deaths. Among those, 4,000 were cardiac, 1,150 sudden, 1,837 MIs, and 1,490 strokes. And that's only to say this is a big study, a lot of people. And the omega 3 wasn't associated with lower risk of mortality, death, sudden death, myocardial infarction, or stroke. So all those reasons, people that think it's going to help, if this is part of the reasons, didn't work. Diabetics. So here we go from New England Journal about 8 years ago. 15 or more than 15,000 diabetics without evidence of heart disease and got either placebo or the omega 3 for 7 years. There was no difference again in the number of serious vascular events. So we keep going. Here's one. Let's see, where is this? Oh, I don't know if I put it. This is JAMA, and again, 20 years ago, but it looked at 20 cohorts from 7 countries, 11 different types of cancer, look for cancer benefits. One of these studies found a significant increased risk for breast cancer. One found a significantly increased risk for lung cancer. And one of the studies showed a decrease for lung cancer. But all put together, there was no advantage for cancer. Let's see. Whoops. How come you're not changing? All right, here we go. In people with cardiovascular risk factors, okay, limit it just to those people. And here's 12,500 patients, again, followed for 5 years. And again, daily treatment didn't reduce cardiovascular mortality or morbidity. So we keep going. And by the way, this does have a reason. The study, I think it'll be number 11 or 12, gets to the recent one that I wanted to touch on. So here's one cardiovascular outcomes in people who are diabetic or had dysglycemia anyway. And daily supplementation didn't reduce cardiovascular events. Moving right along. This is from the WHO. This was just last month. They updated their guidelines in regard to all kinds of things, including omega 3s. But, it's worth looking at the other things that they touched on. And these guidelines apply to people with normal cognition or mild cognitive impairment. More than 57 million people worldwide have dementia, more than 7 million in the US. Most of it is Alzheimer's. And it's interesting that I love this part, up to 45% of dementia risk can be attributed to modifiable factors like smoking, alcohol, social isolation, not exercising, air pollution, or diseases like hypertension, diabetes. So they do the general recommendation: stop smoking, exercise more, eat right, and nobody wants to do that. But they specifically don't recommend vitamin B or E, omega 3 fatty acids, or multivitamins to reduce risk because they didn't work. And then menopausal hormone therapy was not recommended to reduce those risks. All right. Then we get to the one that actually started this whole thing. This came out just last month. Association between omega 3 supplements and cognitive decline in older adults. And this is from a weird journal, the Journal of Prevention of Alzheimer's Disease. And I'll bet every one of you gets that at home and read it frequently. It was interesting. This one pointed out that the omega 3 supplementation was associated with accelerated cognitive decline in people that already had some cognitive decline. In folks with normal cognition, no dementia whatsoever, didn't matter, didn't help, didn't hurt. But if you already had a little dementia, it significantly accelerated it. And I listed here the different studies, the different scales that they use to measure that. I got to tell you, I am not familiar with most of these scales. Mini-mental, yes, but the others I don't use, but they did. Um, so that would be I would think for a lot of people taking this would be a scary thing that if you could get dementia, it's going to get worse much quicker. And I think, all right, so that's it on the omega-3s. Let me just open it up for a minute. Comment, fish oil, omega-3, before we move on to a couple other somewhat similar topics.
Is dietary
Rebecca?
dietary intake of fish like twice a week recommended then for, I'm assuming anything you take via your diet is going to be better than a supplement.
Yeah, diet's always better than a supplement, but to me, the message was this isn't a fix all, it isn't a fix
Yeah.
anything. And if you've already got a little dementia, it's a accelerated. And I don't know, the whole breast cancer, does it make
Yeah.
breast cancer? I don't know. The one study that looked at it said it did. I don't know how true that is, but it was a pretty big study.
Yeah, hey Greg, this is Dave Shepard. Yeah, I think the
Yeah.
quality of the supplement matters too, right? Whether or not it's esterified, how it's
Mhm.
processed, there's a lot of variability in there. And as with a lot of the supplements, you never quite know what you're getting. And that's the
Right.
reason I think I don't know what is the FDA approved fish oil that is the one you have to get with by prescription. That's the one that the cardiologists really push when they want to use a fish oil.
Yeah. But even then, they're doing it based on a hope and a prayer, certainly not on the data. Because at least in the RCTs, they were using standardized uh, fish oil, omega-3. So, I mean, going for the best. And there were a couple that did it based on dosing, more or less than 1 gram, um, and it didn't come through. So I think this is a lot of hope and prayer.
What do you see
Okay,
as the most common side effects of taking fish oil?
bad breath. I mean, well, of course now, if your memory's not so good, you're going to get demented quicker. But I think day to day, the worst is just halitosis. Not a lot of bad side effects, and maybe if you're an introvert and don't want people around, maybe that's a good thing. Okay, well, as long as we're talking about dementia, um, let's go to vaccines for a minute. So for everybody 50 and older, you don't have to raise your hand. But if we were sitting in the same room, I'd say, how many of you have gotten your Shingrix vaccine? Um, it's amazing. This study's been repeated 3 times, as far as I know. 24% lower risk of dementia in older adults in skilled nursing facilities who got their Shingrix vaccine. Um, There have been multiple studies in other countries found the same result over and over. And yeah, there could be confounding, could be vaccine bias, could have influenced the outcomes. Hard to believe it would be by a quarter. Lee, were you going to say something?
No.
Okay. Um, there was a study in the Annals a few years back. This is a 2-shot vaccine, 6 months apart. And even if you got 1 shot, there was a 6% decrease in dementia at 4 years. So there you go. Shingrix. Oh, okay. Well, let's keep going. RSV. Recently, there's an article, RSV vaccine, lower incidence of dementia. Flu vaccine, um, in a study 4 years ago, showed it reduced risk of dementia by up to 40% in people that had had 6 out of 8 consecutive years of vaccine. Again, that's a big gap. Tdap, herpes, well, we talked about Shingrix, but Tdap and pneumococcal also associated, each one with a 3% reduced risk for developing dementia from that same, well, a similar journal of Alzheimer's disease. That's just from a few years ago. And then this was just recently, April. High dose flu vaccine instead of standard dose flu vaccine in people over age 65 led to a 20% lower risk of dementia. So just there's something about getting vaccines that, again, significantly, and I don't know, nobody's done the study to show what if you get all of them. You're caught up on your vaccines, you get them every year, they're high dose, you got your Shingrix, you got your RSV, you got them all, your Tdap is up to date. Is it additive? I don't know. Be interesting to find out, but I'm not sure anybody's even going to look. All right. Any questions? I was going to do this next month when I talk about vaccines, but because it had to do with dementia, I just threw it in with today's. Couple more things and then we'll just open it up. Okay. This also came out recently. All those glucosamine chondroitin people, here was a recent study showing that glucosamine increases dementia, crosses the blood. So there's not just a funny correlation, there's a reason for it. It's able to cross the blood-brain barrier, and it participates in pathways involved in protein glycosylation, and it could lead to it. So here's 41,000 patients with mild cognitive impairment, and glucosamine led to a 25% higher likelihood of progression to dementia. Again, it's like the one we talked about a few minutes ago, like the omega-3, it just moves you there quicker. Let's see, 24,000 patients with established dementia, it was associated with a 25% increase in mortality. And in this randomized control trial, about 8% of patients, in both cohorts, had glucosamine use. Anyway, I don't know what to do with this other than it's just another one of those popular, over-the-counter medications that's sort of a hope and the prayer that I guess my arthritis will go away, my muscles will get stronger. I don't know. But if people knew this information, maybe not so much. All right, that is the end of the dementia part. Any questions or comments or discussion? I have one more thing to throw in, but this is where we leave dementia. Okay. Last one this one's fascinating as well. A few months ago, started reading about this. Vitamin K, this is the opposite. Good thing. Vitamin K supplementation reduced progression of vascular calcification in patients with diabetes, end-stage renal disease. The study did not include patients with symptomatic coronary heart disease. It was just these two categories, the diabetes and ESRD, but it did lead to believing, well, maybe we look at the normal population. Does this help? Now, I wouldn't run out and start buying vitamin K, which is why I put down here the good sources of vitamin K in your diet. Everything's better if you get it in your diet. So, dark leafy greens like kale or spinach, cruciferous vegetables, except for George Bush, who won't eat broccoli, soybean, canola, avocado oils, cheese, especially cheddar and Swiss, egg yolks, chicken liver. These are all good sources of vitamin K. Anyway, it was it was a really fun study because it was looking a lot at calcium scores. So there was a really specific, objective, measurable outcome other than just clinical outcomes that take years and years. This was looking right at the calcium scores. Uh, and that was everything I had to present today. Questions on any of this?
Hey, Greg, Lee Annenberg here.
Yeah, Lee.
We don't see much warfarin being used anymore, but
Right.
there are still a few who have either the actual indications for it or have had documented bad results from the oral, the NOACs and DOACs. So here's the proposition. For some of the elders who become very finicky, poor eaters, they often don't eat as much salads that you mentioned, and their INRs become very irregular and hard to control. And they're either too high or too low, and they don't even out. And so, starting about 30 years ago, I started putting these people on a very low dose of oral vitamin K. And there are two published studies that the Cochrane database reviewed in the past that show that you can stabilize the INR with oral vitamin K. The doses they used were very small. One study used 150 micrograms a day, and the other used 175. One of the two studies was equivocal for benefit, and the second study showed clear evidence of fewer really high episodes and fewer low episodes of INRs. They didn't have included in those two studies outcomes as to reducing strokes or reducing bleeds. But one of the unusual uses of oral vitamin K that occasionally may be helpful for people that have wild INRs and you can't control it.
Yeah, you and I are showing our age by knowing about this. And I've had a couple patients that I've done that with that had diets that were all over either eating a lot of spinach and then none, for a week, and their INRs were up and down. And we did this just to stabilize. Um, I would tell you the other thing is, even with valvular heart disease, I see more and more people using DOACs, even though it's off label. Um, some of the factor deficiencies, I see oncologists occasionally using them. And then by this time next year, we should have the factor 11 inhibitors available, which probably, based on the early data, should replace DOACs within 3 or 4 years. So it looked like it because the nice thing about them, instead of comparing them to placebo, they're doing the comparisons with Eliquis and rivaroxaban for the factor 11 inhibitors. So it's to replace what is the standard care in comparison, not placebo.
In the chat box, Lovaza and icosapent were mentioned. I wonder if those were the prescription ones that you were mentioning. Melinda and Vanessa, if you want to comment on that. Thank you for your input. And Leah and Linda, some possible side effects to fish oil, I think. And then finally, what about these vaccines and decreased dementia risk? What would be the reasoning for that? Great comments in the chat.
There's just theory about that it has to do with inflammation in the brain, and anything you can do that decreases CNS inflammation would be a useful thing. Oftentimes with inflammation, you get residual scarring left behind. And so if you get one of these infections and you got some CNS inflammation and scarring left behind, I don't know. All I've seen is theories. I'm not sure I've seen really good data on why it happens yet.
Well, thank you so much. Appreciate you putting this together for us, Greg. And as I was talking about this learning community that's going to be ongoing first Thursday of each month, I did forget to thank you, Greg, for establishing the Journal Club and making this one of our routines and traditions for this community. And it's because of what you did with Journal Club that we've been able to extrapolate and make this learning community ongoing.
Yeah, it takes a village.
Well, thank you everyone for joining. We will see you next month. We'll try to get this material out onto the website and sent out by email, but appreciate your participation and hope to see you next time. Bye-bye.
Thank you.
Thanks.
Thank you.
Thanks, everybody. That was great.
You.
Hey, Trav. Oh, too late.
I'm not sure what his comment means.
Which one?
Oh, Travis.
Travis comment? Oh, yeah.
Probably a typo there.
I saw one comment that he wanted us to target provider groups and leaders. Yeah. And so I certainly, Vikas should be, I'm not sure he was on today, but
No,
he
he's
certainly,
out of state. Yeah, he's on vacation.
yeah. So we
Yeah.
can certainly reach out to Vikas. I can reach out to Shelley. I didn't see anybody on here from Destiny. So that would be Abu Abba.
He was on. Dr. Abu Abba himself was on, I thought, for a moment.
Oh, he was? Oh, that's good.
Yep.
Then he should know.
Okay. And Jane was on. She's with long-term care rehab with Dr. Esfahani's group. Yeah.
Okay.
Yeah. And I haven't pushed Vikas much because he's a board member, but he does have that duty as a board member too to spread this information and help us craft
Yeah.
it. If he thinks that this is not accessible to the providers in his group, then he has
Right.
a big thing in it. So, yeah. Well, thank you
Yeah.
so much. Yeah.
Yeah, and I don't know. I mean, I can reach out to Longevity, and you can certainly reach out to Optum. I don't know how many. I sort of glanced at the participants, but I didn't see all of them. But I don't know.
Yeah, I
Yeah, I
didn't
don't know.
see anyone from Optum today, so it's but I will definitely highlight it more.
Yeah, and it would be nice, especially if we're going to get towards CME, to
Oh,
more formally get some feedback.
yep,
Because we don't want to be presenting things that people didn't think was useful.
yep, exactly. Yep, perfect. And that's built in, of course, to the CME mechanism. So I'm also
Yep.
hoping that goes through. We have to talk to the accreditation agency again tomorrow. They had some questions. They just haven't done this kind of accreditation for a series of monthly presentations before. So
Yeah. Okay. Well, we'll see what happens. Saying thank you for all your hard work, for your 4-year stint, or is that what it was? 4 years as president.
yeah, I think 4 or 5. It kind of blurs.
Yeah,
Well,
it does get blurred, doesn't it? But you did such a good job.
thank
You
you.
know. And Dave, you know that you're in line when Rebecca gets tired of it. You're going to be next in line.
Yeah, I'm trying to stay out of line.
He almost got pushed into it this year.
Yeah.
We thought, gosh, who's going to be the treasurer?
Oh, I know.
I'd rather be the guy in the chair, not not taking the stage.
Yeah, I remember my 2 years doing both, president and treasurer, because we had somebody quit. But anyway, Dave, you would be fine. Oh, hey,
Okay.
Dave, I'm going
Thank
to
you.
hang on just a second. Dave, stay on.
Okay.
I got a call from Tiffany Boland. And I want you just to listen in.
Okay.
Tiffany.
Marie. Oh, hey, how are you?
Hey, I'm fine. You're calling about Holly, aren't you?
Yeah, Marie asked me to give you a call.
Yeah. So tell me, and I should just let you know this is perfect timing because I have Dr. Shepard on another line here with me. And I'm just trying to figure out with the behavior tracking and Holly, what we're doing and why we're not documenting everything. Or
So they definitely should. And I didn't know that they weren't documenting behaviors until Marie reached out to me to tell me. So I can tell you that I have trouble with them putting the behavior monitoring in And usually when I do their chart checks for their new admission charts, a lot of times they're missing the behavior monitoring and I have to add it myself. So I don't think they're paying very good attention to the behavior monitoring, and I don't ever see anybody documented for having behaviors.
Okay.
Yeah, it's not because I don't bring it up.
Yeah, Dave
Yeah.
says it's not because he doesn't bring it up.
No, and I'm sure it has nothing to do with, any of us. It seems like, and Dr. Shepard and I kind of talked a little bit about it before, even no matter what my recommendations are for them, a lot of times they take it with a grain of salt and don't follow the recommendations, or they kind of put their own spin on it, or do the things that they've been doing. So it's been an ongoing problem. Like, a lot of times they don't even want me to come down for my visit, and they want me to do it remotely. And I think it's so that they can continue to do things their way.
That's a problem, especially in rural facilities. Stay out of here. We don't really want you. Don't want anybody. We moved out to the boondocks so nobody would look at us.
Yes, that's exactly how they act. Like, they're usually very short with me. Like, they seem appreciative, and Acacia will reach out to me for certain things like chart checks or recommendations. But when we're actually talking about systems, they routinely don't like me to mess with things, and I usually have to go in and do it myself.
Yeah, and that's not a reasonable long-term strategy.
No.
Okay, so obviously you and Marie have talked about this.
Yes.
So I think the next step is Marie needs to involve Cynthia, and then it's going to have to be Acacia and Cynthia and you and I and Marie, all of us coming together to say, here's what's recommended and acceptable, and here's what's not.
Absolutely. Yeah, they're not documented. We know they're having behaviors. They have a lot of residents with psych issues on psych meds. We know there's behaviors. We have to justify the meds.
Right.
So they really do need to document those. It's not going to, I think they look at it as it's going to get them in trouble because they're having behaviors.
Yeah.
And they're looking at it the wrong way.
Yep.
Can
Dave,
you hear me,
your
Tiffany?
thoughts?
Yeah, Tiffany, can you hear me?
Tiffany, can you hear Dave?
Yes, I can.
Yes.
Okay. Yeah, so my experience has been the same as yours, Tiffany. They kind of put up with me. Frankly, I'm surprised they haven't kicked me to the curb. But yeah, there's, other concerns besides the behavior tracking. But in this one particular case, I think it is because they know that this person is not going to do well in their facility and they want to transfer the person somewhere. And if that person has a lot of behaviors that are documented that are really egregious, then transferring them somewhere is difficult. So actually, I called Pioneer, who does better with these kind of patients. And I know they sent a referral to Pioneer. It just, I don't like to take patients away from them, but, if they're not capable of handling the person, then they probably should be somewhere that can handle them. So I kind of am trying to help with that process, but I think in this particular case, that's why they don't document the stuff. And to me, it's pretty obvious that that's why they're not documenting it, which I understand from their perspective.
Do you agree with you?
Yeah, I that's probably exactly what they're doing. And I think they take that page out. Hospital does that to us all the time, right? They don't give us the behavior note. They know that maybe we won't take the patient. And I could see why they would want to try to do that, but it doesn't. At the end of the day, if we don't transfer the patient, now it does them a disservice, because if they need medication or they need something, we have no evidence of any behaviors existing.
Yeah, and on this particular patient, I think I actually had a conversation with them before they admitted him, because Acacia wanted my opinion. And I don't think they do very well with behaviors out there. So I told them, he will be difficult and you will struggle with him. But there's a certain financial component to this as well. The pharmacist out there also brought to my attention that when they send somebody to the hospital, they're not completely discharging the person. They're leaving the medications active. And that has led to some near med errors, because the pharmacist can't tell, has trouble reconciling the medication list. And I don't know if that's typical practice or not. And from my experience, I don't think it is. I think we talked about it previously. I'm worried about a med error because of that. But, they kind of have their own processes. So they only listen to so much of what I say anyway.
Buildings. And most of our other buildings do DC them from the computer. As long as if they're admitted, then they DC them. They usually do it in case they just are an ER and come right back. But if they're not back by midnight, then typically we remove them and put them on a bed hold and take them out, so that they would have to be completely readmitted. And they're probably trying to save time, but you're right, it could definitely cause med errors and other problems.
Yeah. So I'm trying to stay in my lane, but sometimes I'm not sure where my lane ends and theirs begins.
Well, I do feel like I agree that since they have been talked to by myself and I believe both of you guys, and I think it's not anything new. I think people have told them these things before, that we probably should have a meeting with Cynthia and the higher ups. And we're actually having an on-site, I think, in 2 weeks. If Acacia and Amy are coming to the on-site, it might be a good time where we can just pull them aside and have an in-person meeting instead of a phone meeting.
Okay.
And kind of just document that and have Cynthia present and discuss all those things, and hopefully that will help make a change.
Yeah, let's make sure we reach out to Marie and Cynthia to make sure that happens and doesn't get forgotten.
Absolutely.
Yeah, because you don't want survey to show up and have a surveyor who would, with the new guidelines, they're just all over stuff, say, yeah, this is pretty egregious. We're going to cite this at a high level.
We definitely don't want that. And I told Marie I would follow back up with her after I spoke with you.
Okay.
And let her know kind of what we discussed and what the plan is. So I talked to her this afternoon. I'll see if she's in agreement with doing that in-person meeting, or if they want to do a phone meeting now and then maybe follow up at the in-person, or how they want to proceed with it, since I have talked to Acacia about these things before.
Yeah, and maybe what I would do, tell them that we're going to have an in-person meeting about this in 2 weeks and see if things don't suddenly just change.
Okay, I can do that too.
Yeah.
Usually Acacia is really open to the conversations, and then after we talk, it seems that whatever we talked about just kind of goes back out the window.
Yeah. So. Okay.
Yeah, they're going to know where this came from. So
yeah.
We'll see if they still want me around after this or not. But.
Oh, they will, because I don't know what we would do to replace you. So, okay.
I mean, no matter what the physician is, even if they wanted to replace you with a different physician, it's not going to change the regulation.
No, it doesn't. And, having psychiatry out there has been helpful, because, having one person say things is great. But when another person's saying the exact same things without any prompting, that has really kind of helped. And so I think that has been beneficial. But evidently not to the point that we're tracking behaviors, because I know that comes up in our psych meetings.
Yeah. Okay. All right. Well, thanks everybody. And Dave, you won't be at that meeting, but I think I know which meeting she's talking about, and I'll be there and represent.
Okay. Yeah, I think we'll probably say the same thing.
So we got to track what's going on before we can make good decisions.
Absolutely, I agree.
Okay.
All right. Thanks, guys. Have a good weekend.
Let her know the plan.
Okay. Thanks, everybody.
Thank you. Okay, bye-bye.
Thanks, Dave.
Yep. Have a good one.
You too.